And we move on to the next speakers. It's Susanna Myrnerts-Ho, pediatrician, PhD, and Nicolas Pejovic, neonatologist, also PhD, in both clinical researchers affiliated to a Karolinska Institutet. And he will present about the laryngeal mask airway and for resuscitation and surfactant delivery. Yes, the pointer is there.
And you push where? This.
The big green button to move forward.
Okay, hello everybody. And me and Nicolas, we have been engaged for more than a decade in laryngeal mask airway research, mainly in Uganda and in Vietnam. And I will refer now to laryngeal mask airway, this long word, as LMA, so it gets a bit shorter. And we will focus first on LMA in neonatal resuscitation, and then I will move on to Nicolas will talk about LMA research with surfactant treatment. And the story of LMA began in 1981 with Sir Archie Brain in London, an anesthesiologist. He was looking for like an easier and less invasive airway that could be used also by unskilled health workers. And this has become like a great game changer in anesthesiology and has since about 20 years also have sizes for neonatal use. And also the ones like this one on the top, the iGel, which is a non-inflatable one. And as we said, the effective ventilation is the cornerstone of neonatal resuscitation, and prolonged ineffective positive pressure ventilation, or PPV, that can lead to the need of advanced resuscitation such as chest compression or intubation. And there are some evidence that every 30 seconds of delay in initiating PPV can actually increase the risk of death by 16%. And the face mask ventilation, or FMV, that we sometimes call it. Also, it still remains the main interface that is used for example, for a training program as helping babies breathe. But it's a equipment that is still lacking in many parts of the world. It could look like this, for example, in some neonatal units. And it's quite a difficult task to get a good ventilation with these devices. A lot of leakage that also makes air not entering the baby's lungs. And endotracheal intubation is, of course, the obvious option then, but as we see, as around 95% of all resuscitations of newborns are taking place in low-resource settings where it's midwives who resuscitate the babies, this is not an option. And can then LMA be something that can improve ventilation in these settings? And there are some evidence. There is now it's a meta-analysis from last year where they looked at laryngeal mask airway compared to face mask ventilation, and they showed decreased probability of failing to improve PPV, decreased use of endotracheal intubation, reduced time to heart rate over 100, and also no difference in admission to NICU, air leak, and soft tissue injuries, SAEs, or survival. And there is a new also systematic review and meta-analysis who have focused also on the same topic, but in low-resource settings. And they also included intubation, but they had very few studies comparing LMA and intubation, so they couldn't really draw a conclusion on that one. But they also show that lesser need for intubation, and they concluded that LMA is more effective than face mask in delivering PPV in term infants in low-resource settings. So advantages and disadvantages. We can say that it's a lower risk, I would say, with LMA compared to endotracheal intubation with airway trauma, laryngospasm, hypotension. Easier training than intubation. Here we have a lot of experience from our research group, from our large trial, which was published in New England in 2020, where we did a study on resuscitation with LMA as first device, and it was only midwives who were using the LMAs, and we trained over 300 of them, and we had nearly no severe adverse events in this study, so it's a very easy task to learn how to use LMA. But compared to ETT, it doesn't have you cannot really suction the trachea, so that is a problem, of course, if you have a lot of mucus or meconium. There is also very few devices, just one device right now that is registered for infants under 2 kilos, and that's the AirQ here. And there can also be higher leakage than intubation if you have high resistance of the lungs. But the recommendation is now that LMA is recommended as an alternative secondary device for neonatal resuscitations for infants over 34 weeks, over 2 kilos. And the question a bit is, but will the laryngeal mask or the LMA become the new preferred primary interface in neonatal resuscitation? And what we see now is that LMA is underutilized in many parts of the world. There is a big difficulties, as you all know, translating scientific research to clinical practice. And there are some recent studies that show that very few centers use the LMA, and among neonatologists, there are many who refer to not having any experience of using LMA. And also here from the side in Sweden, we hear a lot of maybe that many neonatologists prefer intubation, actually, so they don't want to shift to LMA use. But we see a great future for LMA, and especially from our experience in Uganda, where we use the LMA also off-label a bit with the smaller children under 2 kilos. We saw a very good effect. So examples of research gaps and research question now coming is smaller sized LMA is feasible, safe and effective in neonates under 1.5 kilos. And we have ongoing studies on smaller sized LMAs, and hope that there will also be studies coming up in neonatal resuscitation, including prematures in the future. So, yeah.
Thank you. So now we understand that we have a new interface. As it always happens, things start with adults, then it goes to the newborn, and last is the preterm. So we heard it's really surfactant was the first drug that was developed specifically for the preterm. And as we also heard this morning from Joy Lawn, we are all aware that really the next big step is to address the problem of how to take care of the sick preterm. And I really liked what we heard here from Ulla. Is this too easy to be true? Because when we started the neonatal using the LMA, it was my first experience putting an LMA and ventilating. I said, my daughter that's 10 years old, she could resuscitate this baby as good as I would just, with a 5-minute training. So how about doing this with surfactant delivery? So RDS, that's like the major reason why we're losing our preterm. The fundamentals of this is really lack of surfactant in the preterm lung. And it's not only the drug, it's how do we deliver the drug. So traditionally, we were giving this drug for babies that were on ventilators, and many studies show that this was one of the really major steps in high resource settings to decrease the number of preterm death. And I think as a doctors, there's 2 drugs that are like miracle drugs when you give it to the patient. One, it's when you're treating migraine with a patient giving Imigran, where it's just like heaven opens. And the other is as a neonatologist when you give surfactant. So could a midwife give surfactant, for instance? And we know that what has been popular after giving surfactant in the mechanically ventilated baby, and this was pioneered, in fact, in the Scandinavian countries, was to intubate, give surfactant, extubate, and keep the baby off mechanical ventilation. And that is something we've been doing for 25 years, and it's amazing to hear that you're doing this skin to skin, because this, one of the problems is that this is really a quite difficult intervention. We use, in our settings, 5 drugs for the baby. I would think that the whole intervention takes 1 hour, and about 3 health workers, doctor and 2 nurses are working on this. So this works well, but I imagine even the level of skill you need to do it on the tummy of a mother, if you're keeping skin to skin, would be even harder. So SALSA is the idea of delivering surfactant through the laryngeal mask airway. And we have now several small studies that show that this is feasible. That the obvious benefits is that we don't really know what level of sedation, but clearly you can do it with less sedation than ETT tube. You don't need laryngoscopy. You don't. It's also very fast to do this, and you could, since we have shown that midwives can resuscitate with laryngeal mask, why couldn't our NICU nurses give surfactant in places where of scarcity? So we still have lots of research, of knowledge gaps, and this is a way from Sweden how we hope now to contribute for the next step, is that there really aren't any laryngeal mask airways for babies under 1,500 grams. So from working in Africa, we've come back to Sweden, and we can't give you all the details, but basically we're hoping to have devices now for even the smallest babies, both for resuscitation and surfactant delivery. But we need to know, is it as effective? Is it cost effective? How to sedate those patients? There's lots of questions that remain. This is the trial we are planning to conduct in Vietnam, and Vietnam is one of these interesting intermediate places, and I think it's probably in many contexts too early to start with the surfactant. It's still an expensive drug, but we need to be there and to know maybe we can reduce the time of babies on CPAP, for instance, and we know that it's a big. I've been in Africa in places where all the CPAPs are used, and there's a new baby that comes. If you can half the time on CPAP, that would be a great impact, I think. So maybe you could even shift to lower resource countries if this works. So we hope to be able to present those results if we can move ahead on babies above 750 grams. Thank you very much.
Thank you very much, Susanne and Nicolas.